Today we're examining acute mediastinitis. This is a critical thoracic infection, and what makes it so dangerous is its rapid progression and, frankly, its often lethal consequences. We're going to break down this complex clinical challenge, looking at everything from its causes all the way to a new method for predicting patient outcome.
So here's our roadmap. We'll start with a clear definition, then get into its causes and how it develops. After that, we'll cover the diagnostic markers, look at surgical management, and finally, we'll dive into that novel approach for predicting how a patient might fare.
All right, let's begin by establishing exactly what we're talking about. Understanding the precise nature of this disease is really the foundation for everything that follows, recognizing it and, of course, treating it effectively.
So, medically speaking, acute mediastinitis is a really aggressive inflammatory process. It happens right inside the loose connective tissues of the mediastinum, that central compartment of the chest. When this normally sterile space gets invaded by bacteria, it kicks off a fast-moving local and systemic inflammation, which can lead to cellulitis, abscesses, and widespread tissue death.
And to really underscore just how severe this is, look at this number. The source material reports an overall hospital mortality rate of nearly 32%, and that's even for patients who get surgical intervention. This figure just highlights what a persistent and formidable challenge this condition is, even with all our modern intensive care capabilities.
Now, understanding where the infection comes from is absolutely paramount, because, as we'll see, the cause has a direct impact on the prognosis. So let's examine the primary sources.
The source of the infection can vary quite a bit. The most frequent cause is actually iatrogenic, meaning it's a complication from a surgical or endoscopic procedure. Next up is trauma, then we have descending necrotizing mediastinitis, and finally, perforations related to advanced cancers.
But what's really striking here is the stark difference in outcomes depending on the cause. The data shows a 100% mortality rate for cases that have a neoplastic origin. That's a devastating number. Descending mediastinitis also carries a very high risk, at over 33%, while the iatrogenic group is a bit lower, at 26.3%.
And this is a point that can't be stressed enough. A significant number of these cases are descending infections. They actually start in the mouth and throat. Think about it. A deep neck infection, like a dental abscess, can travel directly down along the connective tissue layers into the chest. It creates this dangerous, direct pathway for contamination of the mediastinum.
Okay, let's turn to diagnosis. With something this aggressive, early recognition is absolutely key. And it turns out there are specific biochemical markers, things we can test for right at admission, that are powerful clues to a patient's state and their potential prognosis.
When you analyze the preoperative lab work, a very distinct pattern emerges in patients who have poor outcomes. Specifically, we see elevated inflammatory markers, like C-reactive protein and procalcitonin. That's combined with anemia, low protein and albumin levels, and low sodium. Each of these is a statistically significant predictor of mortality.
So given that diagnosis, the management has to be swift and it has to be aggressive. This brings us right to the core principles of how you intervene, both surgically and with supportive care.
This quote from the source material just perfectly captures the surgical philosophy here. The strategy isn't subtle at all. It's a direct assault on the infection, with three main objectives. So let's break that down. The objectives are really threefold, and they're sequential. First, you have to control the initial source of the contamination. Second, you establish wide, aggressive drainage to get all that purulent material out. And third, you have to perform a thorough debridement, which means removing all the non-viable, necrotic tissue that's just fueling the whole septic process.
And remember those descending infections we talked about? Well, in those cases, the involvement of a maxillofacial surgeon is absolutely indispensable. Their expertise is required to get in there and eradicate the source in the head and neck, whether it's a dental abscess or an infected salivary gland, and to effectively drain the associated deep neck spaces. This stops the continued seeding of bacteria into the mediastinum.
Finally, let's look at a really interesting, data-driven approach to predicting patient outcomes. This is a crucial tool for tailoring therapeutic strategies right from the start.
And these visuals illustrate a key finding brilliantly. The risk of a lethal outcome goes up in direct proportion to the number of pre-existing health problems a patient has at admission. And it's the same story after surgery. The development of postoperative complications, especially 3 or more, was associated with 100% mortality in this particular study.
So, based on these strong correlations, the researchers proposed a prognostic method. What it does is it uses 8 specific clinical and biochemical parameters, all of which are available within hours of a patient's admission to forecast the likely outcome.
The 8 parameters are statistically consolidated into 3 composite factors. Factor 1 they call proteinic status, and it combines things like hemoglobin and albumin. Factor 2 is the inflammatory status, using white blood cell count, CRP, and procalcitonin. And Factor 3 captures the general risk, and that's based on age and the number of comorbidities.
And this table here defines the critical thresholds for each of those factors. So for instance, a Factor 1 score below -1.4, a Factor 2 score above 1.0, or a Factor 3 score above 0.4, all of those point towards a prediction of death. Recovery is predicted when the values are on the more favorable side of those lines.
And this flowchart shows you the practical application. Patient data comes in, it's standardized, and the 3-factor equations are solved. If 2 or even 3 of those factors indicate a poor prognosis, the patient is immediately flagged as high risk. And that prompts consideration for a more aggressive surgical treatment, maybe modified antibiotic therapy, and enhanced supportive care right from the very beginning.
So, this leaves us with a pretty compelling question for the future of critical care. As we continue to refine these kinds of data-driven tools, how can their systematic integration into our clinical protocols fundamentally change how we approach severe sepsis? Could this be the key to improving survival in some of the most challenging medical conditions we face?